Hello, my name is Kevin Corcoran. I'm president of Corcoran Consulting Group. In this program, we're going to discuss what's new in 2019 for the Medicare program. This is important for ophthalmologists and optometrists in order to efficiently and appropriately manage a practice, since Medicare is an important payer and trendsetter. This webinar will focus on Medicare payment issues, coding issues, CMS regulatory matters, administrative changes within Medicare, utilization changes, and CMS Quality Payment Program. When MACRA passed in 2015, it authorized a 0.5% annual positive update to the Medicare physician fee schedule for a number of years, but it was reduced in February to 0.25% by the Bipartisan Budget Act. Other factors also affect the fee schedule. These include the budget neutrality adjustment, down 0.14%, and changes to relative value units on some procedure codes. The Geographic Practice Cost Index floor of 1.0 expired on December 31st, 2017, but was fully reinstated through 2020 by Congress on February 9th, 2018. Lastly, the new 2019 conversion factor is up slightly from 2018. It's positive 0.11%. When we analyze 2019 Medicare payment rules for just ophthalmic procedures, the net effect is a reduction of 1% on allowed payments. The final rule also inaugurates a change in the way Part B drugs are paid. Existing drugs receive a 6% add-on for administration and handling. However, new Part B drugs will receive only a 3% add-on to the wholesale acquisition cost. Within the Medicare physician fee schedule, the most frequent ophthalmic procedure codes changed very little at all. After 2017's large changes in reimbursement for ophthalmic imaging, the 2019 Medicare physician fee schedule is largely unchanged, with the exception of fundus photography, which continued a downward trend. Some payment rates for ophthalmic procedures changed quite a bit in 2019. Those procedures listed on this slide caught our attention in part because we also saw some of them change significantly in 2018. On November 2nd, 2018, CMS finalized the 2019 Medicare facility fee schedule for ambulatory surgery centers. For those meeting the quality reporting requirements, a small increase applies, 2.10%. ASCs not meeting the quality reporting requirements in 2017 are paid a lower rate based on a conversion factor of $45.621. Much like 2018, CMS again reduced the regulatory burden of ASCs quality reporting for 2019. CMS removed one quality measure, ASC number 8, influenza vaccination coverage among healthcare personnel. Data collection for ASC 1 through ASC 4 was suspended while CMS revises them. Most ophthalmic-only ASCs will not report G8907 on claims in 2019, when no adverse events occurred with ASC 1 through ASC 4. CMS kept ASC quality measure ASC 11 on improvement in visual function within 90 days after cataract surgery. However, reporting remains voluntary. CMS changed the definition of device-intensive procedures to those where the device offset is greater than 30% rather than the current 40%. The effect of this change is to increase the payment for these procedures. The final rule lists these ophthalmic procedures as device-intensive in an ASC. One of the device-intensive procedures is the implantation of a miniature telescope. For 2019, this is reassigned to APC 5494 from APC 5495, which lowers reimbursement. When performed in a hospital outpatient department, the allowed amount is $16,234.22. For an ASC, the allowed amount is less than $3,000, which is not viable in that setting. For 2019, CMS approved just one device for pass-through payment, the Argus II retinal prosthesis system. The CPT procedure code is 0100T. It is assigned to APC 1908. The payment rate is $152,500.50. Payment is excluded from being bundled with payment for other procedures. Importantly, the 2019 final rule changed the ASC payment update methodology to use the Hospital Market Basket Index instead of the Consumer Price Index Urban. The impact of this change is a more rapid increase in the payment rates for ASCs than previously. CMS is encouraging migration of services from the hospital outpatient department setting to the more cost-effective ASC setting. At the same time, they are expanding the list of eligible procedures that can take place in an ASC setting. That expansion does not change any eye surgeries. Lastly, CMS again delayed the implementation of the Consumer Assessment of Healthcare Providers and Systems Survey. You can get the full ASC Quality Reporting Manual on the QualityNet website. The most common Medicare ASC payment rates for ophthalmic procedures changed very little in 2019. However, some Medicare payment rates for ASC facility fees changed significantly for 2019. This slide shows those that experienced large increases. There were no ophthalmic procedures that had large decreases. CMS also updated its Medicare facility fee schedule for hospital outpatient departments. Like all of the other fee schedules, there was a small change. For hospital outpatient departments, the result was a positive 1.35% adjustment. Representative Medicare hospital payment rates for 2019 are shown in this table. Note that there are only small changes for all of the common ophthalmic procedures. In the next section of this program, I'll describe the variety of code changes that affect ophthalmology and optometry. CMS introduced a new HCPCS code in 2019, G2012. Brief communication technology-based service, e.g. virtual check-in, by a physician or other qualified healthcare professional who can report evaluation and management services provided to an established patient, not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. 5 to 10 minutes of medical discussion. This pertains to the growing area of telemedicine. CMS stated that the code allows audio-only real-time telephone interactions in addition to synchronous two-way audio interactions that are enhanced with video or other kinds of transmission data. Telephone calls that involve only clinical staff cannot be billed using HCPCS code G2012, since the code explicitly requires direct interaction between the patient and the billing practitioner. Unfortunately, CMS did not state that pure asynchronous modalities would qualify for this code. We'll have more information about telemedicine in another one of our webinars. Next, we'll cover the changes to the coding for electroretinography, or ERG for short. The long-standing CPT code 92275 has been deleted and divided into 3 codes for greater specificity. This grew out of a large increase in utilization of pattern ERG. The first new CPT code is 92273 to report full field ERG, flash ERG, and Gansfeld ERG. The second new CPT code is 92274 to report multifocal ERG. The third new CPT code is 0509T to report pattern ERG. Note that the first and second new CPT codes are permanent Category 1 codes, while this one is a temporary Category 3 code. In general, Medicare and other third-party payers are not disposed to cover Category 3 codes without a lot of supporting evidence, so this will probably be non-covered and a patient pay procedure. Recall that we saw a similar revision of visual evoked potential in 2018 with the revision of the old Category 1 code and the addition of 2 new Category 3 codes. CPT inserted guidance in the manual for 2019 about ERG since there are so many changes. It states, electroretinography is used to evaluate function of the retina and optic nerve of the eye, including photoreceptors and ganglion cells. Multiple additional terms and techniques are used to describe various types of ERG. If the technique used is not specifically named in the code description for 92273, 92274, 0509T, use the unlisted procedure code 92499. On August 29, 2018, Alcon withdrew the CyPass microstent from the market. In the FDA warning that followed shortly thereafter, it states, patients with CyPass device are at risk of losing endothelial cells. Do not implant any other CyPass devices. Return unused devices to manufacturer. Review Alcon's recommendations for patients. From a coding and billing perspective, this means 0474T is presently not applicable to any MIGS procedures. For more information on this important topic, we've prepared a separate webinar with a number of different clinical vignettes. 0506T is a new Category 3 CPT code that took effect in July 2018 and appears in the 2019 CPT manual for the first time. It is used to report macular pigment optical density measurement by heterochromatic flicker photometry. Another new Category 3 CPT code is 0507T, near infrared dual imaging of meibomian glands. CPT makes a distinction between external ocular photography, 92285, tear film imaging, 0330T, and meibomography, 0507T. A new Category 3 add-on code is 0514T, intraoperative visual axis identification using patient fixation. An add-on code describes a service that is always performed in conjunction with another primary service. In this case, the primary service is cataract surgery, 66984 or 66982. The CMS final rule for the outpatient prospective payment system bundled 0514T with cataract surgery for the ASC and hospital outpatient department, so there is no separate payment for it. Within the Medicare physician fee schedule, this Category 3 procedure is not assigned relative value units or any payment. At present, we don't have much information on this new code or how the MACs will handle it. 2 ophthalmic procedures were deleted from CPT, 66220 and 0190T. Neither represents a common procedure. Medicare Part B pass-through payment for Omidria used during cataract surgery ended December 31st, 2017. Subsequently, the pass-through was restored for 2 more years, starting October 1st, 2018, by the 2018 Consolidated Appropriation Act. In 2017, Avedro made an application for a new HCPCS J-code for Photrexa, which is used during corneal collagen cross-linking for keratoconus and ectasia. In November 2017, the HCPCS committee rendered a decision which was unfavorable. Subsequently, during a reconsideration of the application, a new J-code was approved after the professional societies appealed. The new code is J2787. The AMA's CPT panel added a parenthetical instruction to the 2019 manual that permits separate reporting of the medication. Third-party payers generally make their own payment policies and might not recognize this new J-code. Check with the payer prior to doing the procedure. Following ophthalmic surgery, an anti-inflammatory agent is almost always used. For decades, surgeons have used injections at the end of the procedure. On October 1, 2018, CMS granted transitional pass-through status for EyePoint Pharmaceuticals' new product, DEXYCU, dexamethasone intraocular suspension. 2 HCPCS codes were assigned, C9034 and J1095. The C code is used on claims by an ASC or hospital outpatient department to receive the additional payment from Medicare. For non-Medicare payers and for in-office use, the J code may be used. At the end of 2014, Alimera Sciences received FDA approval for ILUVIEN to treat diabetic macular edema. At the end of 2018, EyePoint Pharmaceuticals received FDA approval for YUTIQ, which differs from ILUVIEN in the dosage, 18 milligrams versus 19 milligrams. The FDA has approved YUTIQ for the treatment of chronic, non-infectious uveitis affecting the posterior segment of the eye. The same HCPCS code, J7313, applies to both products. Only the number of billed units is different. It's important to note that Retisert implant from Bausch + Lomb uses a higher dose of fluocinolone, has a different HCPCS code, J7311, and has different reimbursement. Billers should not confuse Retisert with YUTIQ or ILUVIEN. In the next section of this program, I'll describe the regulatory and administrative changes that affect ophthalmology and optometry. The 2019 Part B deductible is $185 and went up only $2 from 2018. Medicare Advantage, as a part of the Medicare population, continues to grow quickly. Medicare Advantage enrollment is anticipated to increase 11.5% in 2019. 36.7% of all Medicare beneficiaries will be enrolled in a Medicare Advantage plan in 2019. Part of the attraction is lower monthly premiums for Part C, down 6% from the prior year. CMS has indicated that 99% of beneficiaries have access to at least one Medicare Advantage plan. Medicare Part D, the drug benefit available to all Medicare beneficiaries, will also see a decline in the average basic premium by 3%. This is the first decline since 2012. Get ready for a new Medicare card. It replaces the old card because of privacy, security, and identity theft issues associated with the beneficiary's Social Security number on the card. The MACRA legislation requires new Medicare cards without the Social Security number by April 2019. The new card uses an 11-digit Medicare beneficiary identifier containing random numbers and characters. New cards get mailed beginning in April 2018. During the transition period from 2018 to 2019, both the old and new Medicare beneficiary identifier number will work on claims. The old Medicare beneficiary identifier number expires January 1st, 2020. A glitch in claims processing for vitrectomy has been fixed. Some eligible diagnoses that were dropped from contractor edits have been restored for 2019, which should improve payments. Of note, on April 1st, 2019, H35.53 will be deleted and H35.52 will be added. In mid-2018, CMS announced a proposal to change how E&M services are charted and reimbursed within the Medicare program. The proposal, known as Patients Over Paperwork, was roundly repudiated by the physician community. Nevertheless, the CMS final rule for the 2019 Medicare physician fee schedule retains some aspects of the proposal and postpones other parts. Unlike other physicians, most ophthalmologists and optometrists will benefit from this proposal in many ways, including increased Medicare reimbursement, primarily due to the impact of I-codes that were not changed in the CMS rules. In 2019, the most important change is a reduction in the documentation requirements for E&M codes. Starting in 2021, CMS plans to simplify payment and further reduce documentation requirements. Of course, plans sometimes change with time. In September 2018, CMS published a proposed rule to reform Medicare regulations that are unnecessary, obsolete, or excessively burdensome on healthcare providers and suppliers. Of interest to operators of ambulatory surgery centers, CMS proposed to no longer require an H&P within 30 days of surgery. Instead, the surgeon and the ASC determine which patients need this comprehensive assessment. CMS proposed to discontinue written transfer agreements for ASCs with a hospital to ensure all physicians at the ASC have admitting privileges in that hospital. CMS admits that this is duplicative or obsolete. Additionally, they propose to reduce some of the emergency preparedness requirements in place for ASCs. The result of the most recent CMS comprehensive error rate test for the time period between July 1st, 2016 and June 30th, 2017 show an improvement in the accuracy of claims. For Part A and B combined, almost $500 billion, there were improper payments of $36.2 billion, or 8.1% of total paid claims. For Part B alone, there was an error rate of 10.7%, and the error rate for DME POS decreased to 35.5%. This graph shows how the error rate changes over time. Since 1996, it has ranged from a low of 4% to a high of 14%. But the standards that were applied were not always the same. There was a significant increase in the error rate in 2009 when tougher standards were introduced to assess errors. Among all specialties, ophthalmology can be proud of the accuracy of their claims for reimbursement and a low error rate. For calendar year 2018, the overall error rate for ophthalmology was 3.2%. Optometry did not do as well. Their error rate was 4.4%. For all specialties, the average error rate was 10.7%, which is significantly higher than ophthalmology and optometry. The budget bill passed in February 2018 changed the penalties and sentences. Investigators and prosecutors will have even more leverage than in the past. Civil and criminal monetary penalties and sentences were doubled and the minimums raised. The maximum fine is set at $100,000. Felony convictions have a 10-year maximum. The Office of Inspector General of the Department of Health and Human Services announced in June 2017 that it is moving away from the annual work plan to monthly updates in the interest of transparency. A recent file had the following on it: identification of HHS cybersecurity vulnerabilities, CMS Medicare Beneficiary Identifier Card, review of postoperative services provided in the global surgery period, inappropriate denial of services and payment in Medicare Advantage. You may remember UnitedHealthcare was sued over their payment by the government. UnitedHealthcare won a reversal so far, but the government may still appeal that finding. The amount of money is in the hundreds of millions of dollars per year. For the years 2010 through 2015, it was $3 billion for UnitedHealthcare alone in Part C. The Medicare administrative contractors recently placed notices on their websites. The Office of the Inspector General reports that Medicare is vulnerable to fraud, waste, and abuse for wet age-related macular degeneration and cataracts, administration of Lucentis injections for wet AMD more than once every 28 days, billing for a second cataract surgery on the same eye, submitting disproportionately more claims for complex than standard cataract surgery. As a result, providers may see more data-driven chart requests by Medicare administrative contractors. In the next section of this program, I'll describe the recent changes of utilization patterns for ophthalmology and optometry. Here are the top 10 eye surgeries paid by Medicare Part B in 2017. The corresponding numbers for other third-party payers are not public. Year-over-year comparisons are always interesting for the significant changes that are identified. When we compare Medicare data for 2017, the most recent year for which data is available, with 2016, the prior year, we see some remarkable things. There were large increases for some surgeries by ophthalmologists, particularly MIGS and placement of amniotic membrane. For most ophthalmic surgical procedures, there were very modest changes. In this slide, we stratified them by percentage change, and we included the number of paid claims as well. History teaches us that big increases or high volumes like these may attract attention from Medicare and other payers. Generally, payers are a skeptical bunch. Providers must be able to support their claims for reimbursement with solid evidence of both medical necessity and appropriate usage. Here is a graphical representation of the trends over the past 20-plus years for glaucoma surgery. Notice how fast MIGS is growing. This slide identifies the changes in utilization from 2016 to 2017 for certain ophthalmic tests and eye exams performed by ophthalmologists. MMP9 assay, extended ophthalmoscopy, and electroretinography increased significantly. Visual evoked potential, ultrasonic biomicroscopy, and fluorescein angiography decreased significantly. Recall that fluorescein angiography changed from a unilateral to a bilateral service on January 1st, 2017, so the large decrease is not surprising. Utilization patterns and benchmarks for ophthalmologists and optometrists are different within the same population. In part, this is due to the intrinsic differences between these eye care providers, but it also reflects different appetites. When we compare Medicare data for optometrists in 2016 with 2017, we see some significant changes. Among all of the diagnostic tests and exams administered by optometrists to Medicare Part B beneficiaries, this slide shows the ones that changed the most. In this slide, we stratified them by the percentage change, and we included the number of paid claims as well. In the next section of this program, I'll describe the changes to the Quality Payment Program for 2019. There is new weighting for the elements of the Quality Payment Program in 2019, which affects providers in 2021. Bonuses and penalties rise to 7% from 5%. A composite score of 75 points is required for exceptional performers for year 3. Quality weight decreases to 45%. Program interoperability, which was formerly advancing care information, remains at 25%. Clinical practice improvement activities remains at 15%, and resource use or cost use increases to 15%. Multiple submission methods are available for MIPS: claims, EMR, and registry. The highest one counts if there are duplicates. There are several steps that you can take to adapt to these changes. Add new CPT codes to your professional fee schedule, note code descriptor and modifier changes, update CPT codes for 2019, review your utilization patterns, and lastly, continue reporting for MIPS 2018 and learn about changes to MIPS 2019. This program is a general discussion of what's new in the Medicare program for 2019. Local variations between Medicare administrative contractors may occur, which are not discussed here. You are encouraged to review official instructions by CMS. This program is not an official source nor a complete guide on reimbursement. The audience is reminded that this information can and does change over time and may be incorrect at any time following its production. Thank you for your attention. For additional information, please contact us at 800-399-6565 or send us an email. We're here to help you.